Thank you, Richard, and welcome everybody. It's great to be here with you this evening. I'm excited for the event we're holding here tonight, an opportunity for us to talk a little bit about the ILLUMISITE platform from a group of community-based physicians. Next slide, please. So I'm Jody Weinzettel. I lead the education and commercial excellence team. And I'm here, as Richard said, to help moderate this evening. In a moment, I'm going to introduce you to the panel members, but first wanted to share that the objectives of the program today are to give you some dynamic experience about ILLUMISITE. We've got 3 folks here who have had a great experience over the course of the last 8 to 10 months. We were just chatting in the panel room here about their experience, so I'm excited for them to be able to share that with you. We've been hearing that we want to hear from people in the community, people who are figuring out how to do this in your setting and what this might look like for your practice. And so I know these 3 will do a great job in sharing what that looks like for them. They also have some cases and some examples they're going to share with you, and talk about some of the learnings that they have certainly accomplished and learned from over the course of their 100+ so procedures with ILLUMISITE to date. Next slide. What you're also going to see here a few times throughout the presentation is these QR codes. This is a way for Medtronic to better understand how you're liking these events, what types of subject matter would you like us to continue. We do these on a quarterly basis, and so we would love some feedback on both tonight's session as well as on future opportunities. And without further ado, next slide here, I'd like to introduce you to our 3 panel members. So first we have Dr. Hoopman. He is currently practicing as a pulmonary and critical care medicine physician at Kootenai Hospital in the Idaho Panhandle town of Coeur d'Alene. His clinical interest focuses upon the importance of early detection of lung cancer and the promotion of lung cancer screening as a valuable tool to save lives. He has been able to design and grow the region's only lung cancer screening and pulmonology nodule center, and he specializes in advanced pulmonary diagnostic modalities. Thank you for being here, Dr. Hoopman. Next, we have Dr. Suri. He completed his training in pulmonary critical care medicine at Mayo Clinic in Rochester, Minnesota, and moved to the Dallas-Fort Worth area in 2011. He then founded the Lung Consultants in 2018 with a vision to establish a state-of-the-art practice to provide comprehensive pulmonary and sleep care in the Dallas-Fort Worth area. He has special interest in lung cancer and thoracic oncology. He completed additional training on ENB and EBIS while at his fellowship, and he was the first physician who brought these minimally invasive procedures to the area. He has performed more than 1,000 ENB biopsies, and he currently serves as the pulmonary medical director at Baylor All Saints in Dallas-Fort Worth. Thanks for being here, Dr. Suri. And lastly, Dr. Gordon. Dr. Gordon is a Colorado native. He completed his undergraduate and graduate studies at Colorado State University in Fort Collins, go Rams, earning a degree in exercise and sports science and a master's degree in anatomy. He completed his internal medicine residency at the University of Louisville and his fellowship in pulmonary and critical care at the University of Cincinnati. He is the director of advanced bronchoscopy and a clinical professor of medicine at Parkview Medical Center in Pueblo, Colorado. Thank you, Dr. Gordon. So with that, we've got an esteemed group of panelists here. Looking forward to kicking this off tonight. And Dr. Hoopman, you are up first. So I will let you take over. And team, just wanted to make sure to mention, if you have questions, please make sure you use the feature at the bottom of your screen, and we will look to do questions either throughout the session or at the end. Thank you so much.
Okay. Thank you, Jody. I hope you can hear me okay. I have control of the slides.
You're all set.
Okay. Thank you, Richard. Thank you for that kind introduction. I'm going to start us off out of the three speakers and just have a handful of slides that will kind of highlight our journey to get to where we are now. We certainly didn't start where we are, and talk a little bit about the ILLUMISITE platform and some of our successes that we've had, and really the experience that has highlighted our program to date. This is where I get to work. This is not a doctored photo. We have blue skies like that for much of the summer. It snows in the winter. I'm in far northern Idaho, about 90 minutes south of the Canadian border, to the east of Spokane and to the west of Montana. It's a beautiful place to live with 4 seasons. Unfortunately, it's also a place that has a very high lung cancer rate, secondary to high tobacco use, as well as some environmental carcinogens and other issues. As a result of that, beginning in 2016, we were challenged with trying to establish a lung cancer screening and also a pulmonary nodule clinic. I had the backing of our institution. We are a 330-bed community-owned hospital, one of the few left in the United States, and we had a very large support from our board of directors with financial support, but also administrative and clinical support. As part of that, we were able to add on to our bronchoscopy suite and bring it up to full, what I consider to be fully equipped status. We started with navigational bronchoscopy at that time in 2016, and we were able to add the ILLUMISITE platform in June of last year. Our first navigational case, as mentioned, was in April 2016. We averaged between 100 to 125 procedures per year. I'm pleased to say our very first navigational case on April 1st of 2016 is doing well. She was a stage 1A. She's still alive, and every time she comes to see me in clinic, she wants to know if she was still the first person who ever had a navigational bronchoscopy at our center. And I try and explain to her we didn't sneak somebody in before her. This is a quick shot. It's a little dark, but this is our bronchoscopy lab. And we actually have rows available for every case. I have a very supportive pathology department. I guess some of the support happened when I just told them that they were going to be present for every case, and they agreed. The blow up or the call out in the bottom right hand corner is representative of the screen that's on the far wall. We actually have a digital connection to their microscope. They are in the hallway or they can be in the room with us. They tend to avoid the fluoro, but I can actually review their slides as they're looking at them. And oftentimes I'll wrap the case before they come in to tell me that we have a positive result. So it's actually sped us up to be able to see what we're doing, and it gives our nurses a better understanding of how to prep the slides and things that they can do technique-wise. Beginning last year, we've done approximately 85 cases. The end counting is because it changes week to week. I have 5 on the books for tomorrow morning, so we'll be up above 90. But we've really utilized the platform to its fullest. And I'd like to just share briefly, and some of the future presenters have some similar slides, so I won't take a long time on this, but I just want to point out the call out box on the left is with the local registration turned off. So this is your traditional view. It appears that we have appropriate alignment to the target lesion. We've done then our fluoroscopic sweep. We've then turned on the local registration, which is the box to the right. And you can see that the alignment has moved substantially, or at least enough that I wouldn't have felt confident with that biopsy. That's due to a multitude of factors. Typically, it's the CT to body divergence that everyone has talked about and heard about. A difference between a CT scan when someone is as an outpatient versus laying on the table with anesthetic in place is one of the main reasons. And we do some things with our anesthesia program to minimize that. But the addition of ILLUMISITE is where we really were able to take this to the next level to account for that difference, make adjustments to the extended working channel, make adjustments to the biopsy tools in real time, and really improved not only our accuracy, but also our confidence of what we were doing. I mentioned we've done about 85 patients. 5 of those patients have had, for the most part, bilateral lesions, or at least separate lobes in the same ipsilateral side. We've had the confidence to biopsy both a right lung and a left lung in one procedure. I do perform an interval fluoroscopic sweep to look for at least a large pneumothorax, but I prepare patients for the fact that we're going to try and get the procedure done in one anesthetic run. We've had, of those 85 patients, we felt that 58 of them were suspicious nodules. That was based upon their size, the location, patient risk factors, and then just overall CT appearance. 56 of those were positive for malignancy, so a very high positive rate. 2 of the patients did move on to CT-guided follow-up biopsy and proved to be positive for malignancy. And then our size has been variable. We've gone down as low as 8 millimeters, and I've got a couple pictures of those. We average about 23 millimeters. We use the ILLUMISITE platform for, at times, fairly large nodules, what would characterize as a mass. I feel that it's a platform that I can still utilize to really optimize tissue sampling of large masses that may have necrotic areas, and to make sure I'm getting viable tumor. As everyone knows, the biggest focus these days has been material available for genetic analysis and driver mutation analysis. So we can use this to really optimize appropriate tissue acquisition. Just a couple of quick cases. The lesions pointed out here, this is superior segment of the left lower lobe. You can see it's in a subpleural location. Traditionally an area that you might have avoided with bronchoscopy. We felt confident with the approach, obtained tissue and had a diagnosis. Patient went on to surgical resection and cure. And then another example, apical right upper lobe, kind of a really difficult place to reach because of its medial location, small. This was an 8 millimeter nodule. This was actually our first case that we chose to do with the ILLUMISITE platform. So rather than shy away from the difficult ones, we decided to start with the tough one out of the gate. This was metastatic renal cell carcinoma, biopsy proven. Patient went on for further therapy and treatment based upon the process and the procedure that we were able to do. So just to summarize, I feel that our experience with ILLUMISITE has been exactly what I was hoping for, and exactly what we were looking for as an institution. We have better localization to the lesion. We're correcting for that CT to body divergence that really has plagued some of the performance in the past. And again, it gives me the confidence that I need to know where the tip of that catheter is located at all times. I can adjust the tool in real time. I can take biopsy samples in a more circumferential pattern. And then I think importantly for a community center, our resources are not limitless. We have to be efficient with what we're doing, and we've been able to shorten our procedure time. There are some additional steps involved with doing the fluoroscopic sweep, but because of the accuracy and the confidence, we're finding our procedure times are shorter. And we average for a full run from anesthesia start to extubation about 42 minutes, and that includes endobronchial ultrasound sampling of the mediastinum and hilum for a positive Rose call. So we have patients in and out of the room in under an hour for a full procedure. And that's my last slide. A couple of references here. I will stop there and turn it over to our next presenter. And I know we have some questions, and Jody, I think we're going to try and tackle those at the end of the procedure, or at the end of the conference, if I'm not mistaken.
You know, I think I'll ask you why we're doing this transition here to Dr. Suri, and you're getting ready to take over. Quick question for you, Dr. Hoopman. So you've had, almost 100 cases. Can you share a little bit about the outcomes that you have seen so far with the procedures that you've done with ILLUMISITE?
Well, do you mean with regards to accuracy or just overall satisfaction
Correct.
with the procedure? So with regards to accuracy, we've been extremely accurate for malignant lesions. I mentioned that we've had a handful, about a third of our cases were not suspicious for malignancy, and they did end up being, the majority of them were inflammatory or infectious lesions. On follow-up CT, most of them have actually reduced in size. We have a fair amount of sarcoid here as well. What I've really been pleased with is when we are doing Rose analysis of specimens in the lab in real time, if I feel that I have appropriate alignment and I've been able to confirm that with my fluoroscopic sweep, and I'm getting a result that is not what I expect. So I expect malignancy and I'm getting a non-malignant call. I will make adjustments real time, change the tool, and kind of do all the things that in the past I might have been maybe not as confident with if I wasn't sure I was in the right place. And we've been able to change negative Rose calls to positive Rose calls intra-procedure because of that. So as a whole, it's giving me exactly what I want. I think from an institutional standpoint, and if I look at my other colleagues I work with, particularly my oncologist and my thoracic surgeon, They actually now look for patients to send to us because I've shown them the power of this in our tumor boards. And I'll get requests and emails and text messages saying, here's a nodule. I think you should be able to reach this. They don't even ask if I can. They just know that we can because they've seen what we've done on the others. So it's been exciting to have colleagues really buy into the technology as well and start to seek out cases for us to use this with.
That's great. And I have just another quick question, and then we'll transition it over. But of all the tools that you used, what's your favorite? And do you use radial EBUS to confirm the location of the tip?
I will answer. I do use radial EBUS, and I like having radial EBUS for confirmation. There are times where, frankly, I've sometimes struggled getting what I want to see with my EBUS picture, or my rebus picture rather. But we do use it for every case. My favorite tool still tends to be, depending on the lesion and the location, either a 21 or a 18 gauge arc point needle. I will go to the gen cut more often than not if I'm getting a negative needle call and I feel like the lesion is there and we're just not sampling it the way I want to get it. And I've had quite a few cases where I was able to obtain it with the gen cut. But I would say the needle's been our workhorse. But we'll use them all. There's not a tool in the cabinet that we haven't pulled out multiple times.
Wonderful. Thank you so much. Dr. Suri, I've got more questions, but we'll save them after your talk.
Sure. Thank you. All right. Well, thank you for a very nice presentation, Dr. Hoopman, and some of the experience we have is similar. I just want to show you, I'm Harpreet Suri. I'm one of the directors of the lung program at Baylor's Kootenai All Saints in Fort Worth. I've been practicing since 2010-11, but I've been doing this navigational bronchoscopy since my fellowship. I just want to show you the journey, how it's evolved. I think initially in the ENB platforms, they all relied on if you can generate the electromagnetic field around the patient's body. And that's how, if you can do that, then you will be able to locate the sensor within that field. But if you can average the volume within that field and use the patient's body as a representative of 3D CT scan, then you should be able to actually navigate that sensor within that airways. That's the first how this came into ENB, and first platform was in 2006. Since then, it's been evolved over a period of years. The things which were changed initially was there were manual registration. The locator guide was not as user friendly, and then we have to use a lot of manual things to just do the biopsy. Since then, the locator guide has improved significantly. Its ability to get the data within a short period of time, and then there's a lot of advancement and depth of the knowledge you can get from that. More recently, the ILLUMISITE platform that came in, and that has added more with the continuous guidance as well as fluoroscopic navigation, which Dr. Todd Hoopman also mentioned. So I've seen the journey for over the last 10 years, and my experience from the beginning using the very initial platform to this is grown, and the success rate. Just want to show you that we use this protocol prior to bronchoscopy, as Dr. Hoopman was also mentioning, that it's very important to make sure that you have the airways, they are open, they don't get atelectatic. And so we work very closely with anesthesia. We follow this protocol strictly. We use total intravenous anesthesia. We use 8 to 8.5 ET tube. We just pre-oxygenate these patients to 60 to 80% rather than 100%. And as soon as they are intubated, we place them on tidal volume 8 to 10 ml per kg and PEEP of 8, depending on if their body habitus, and then maintain about 30 to 40% FiO2. No metal, we don't use any metals around it. And then we use with fluoroscopic navigation, we use the breath hold about 20 centimeter water pressure in inspiratory hold. I'm not sure what the audience here or people who are watching, what phase of their experience they are in, just to show you that what the bronchus sign is for some of these cases. When you see this, and you see the locations, they can be variable, very peripheral, apical, but if you have a bronchus sign, at least that helps you in reaching these nodules more easily than the nodules don't have a bronchus sign. And some of these nodules which don't have a bronchus sign, as this is sitting just above the diaphragm and the left lower lobe, I mean, I use something called a CPR, which is a curved planar reconstruction. And this technique is actually, you are actually mapping the, using the vessels to track the airways. And that helps at least me with some of these nodules. As I'm showing you in these, you can see I'm tracking these airways, which is leading to that nodule. And I can map these airways with the reconstruction technique. And it's the tool available for everyone in PAC system. And I can go very close and know exactly where this airway is leading me to. So this has helped me in the cases which are very peripheral, and I'm not sure if there's an airway reaching to these. It helps me in preparing for these cases. So that's something you guys may want to look at it. So just want to share you a few cases. Again, as I saw Dr. Hoopman's experience, we have the similar sort of cases, and there are no restrictions. Since the ILLUMISITE platform is there, we can reach anywhere in the lung, and there's a confidence with continuous guidance as well as fluoroscopic navigation, and that is built up that the nodules, even with the bronchus sign or no bronchus sign, we are able to reach to these nodules. I'll share you, this is a case, first case after we did the registration and planning. This is a 1 centimeter case in the right upper lobe. And I was able to reach within 2 minutes to the nodule. And then we use the fluoroscopic navigation just to make sure that we are in alignment. The important things, can I pause here? Okay. The important things is once you align these nodules, as there's a CT to body divergence, which is very real. What Dr. Hoopman mentioned, same, is like when you have a static pre-procedure image versus the patient's breathing lung, you will see the variation within these nodules, and you may have to adjust these based on the current position of these nodules within the breathing lung. And with this fluoroscopic navigation, it's a very helpful tool in smaller nodules. And I was actually very close to the nodule, and it brought me even more closer from 8 millimeter to about 0.3 millimeter into the center of that nodule. And we were able to get the biopsy on the first pass, and it was adenocarcinoma. And as compared to Dr. Hoopman, I use more of the forceps biopsies for 90-95% of my cases. And whether it's a smaller nodule or a bigger nodule, and have been very successful and able to biopsy these. Our first pass rate is about 78% in these cases to get the answer. Which one thing I want to point out here is the location positioning of your EWC, which corresponds to your nodule. Majority of times when we use forceps or the needle, you will see there will be a change in the curvature of this EWC. So if you are positioning yourself where once it's straightened a little bit, it's actually seeing towards the nodule rather than is on the side of the nodule. So positioning is very important, particularly if you're using the forceps or needle. But if you're using arc point or gen cut, actually that doesn't change the position that much. It's another case, and this was more in the left upper lobe. Not sure this is gonna go. Okay. And this is a little bit larger. It was about 1.8 to 2 centimeter nodule, but it was very close to the hard border. And it took me a little longer time to reach there because of the airways. And there was also a cardiac movement. Again, we do the fluoroscopic navigation and utilization of the technique where we were able to adjust, but again, it was not much different from where we were within the nodule. This is just to show you how this technique works. You are able to see this nodule very clearly on fluoroscopic view. and you adjust it based on the, you have to mark it and map it with your catheter and corresponding to your nodule. And that's your planned target. And that's just showing you it's registering and it's going to produce the data and where you are within the location of your nodule. Again, that suggests that we were very close to it with the EWC. Again, mostly we again use the force up here. This is also adenocarcinoma. So both of those nodules were first pass, and we were able to get the atypical cells suggestive of malignant cells. Role of, we also do fair amount of fiducial marker placement. We work very closely with our radiation oncologists, and our experience is, a lot of these nodules, which are cancer, stage 1, these patients are not surgical candidates. Some of these radiation oncologists are still using the cyber knife rather than the Novalis, and they still request fiducial marker placements. It depends on your radiation oncology, what is their expectation. So we work with them and able to place the markers. I'll share with you like in the last slide. So this is something which I built up just for the folks over there, the success toolbox, what has worked for us. And depending on where you are in your phase of or experience of the cases you have done, if somebody who's in the beginning, just please select these cases very wisely. Look for the cases with the bronchus sign, look for the cases which are a little bit bigger in size and more in easier proximal location than very peripheral. Planning is very, very important. And I spend a fair amount of time in planning. Before even I start a procedure, I tend to work out where the actual location of this nodule in which subsegment. I particularly use the navigation for only the last 2 centimeters within the nodule. Continuous guidance and fluoroscopic navigation has helped a lot in generating more confidence in reaching these nodules. And you are able to actually recognize more structures when you have a continuous guidance, and it also allows you to take biopsy from different areas. One thing I do is a comprehensive survey before obtaining the first biopsy sample. Even though I am very close to that nodule, I still go and take a look the nearby subsegments or the airways and see if I'm in the best position. Our experience is the first sample is the best sample you get, because once it starts bleeding or has some more secretions, it becomes more challenging. So I particularly focus on my first sample before, and I will go in the best position where I can get the sample. Some of the things which I also use is dilate the airways, because some of the time when you are past second generation and there may be additional airway that may be there, but you don't see it. I just use about 10 to 20 cc's of saline, block it there and dilate, and able to navigate my EWC over into that area. And this works particularly when you are in the difficult airways and you have to navigate, so the tools are still there. You have different EWCs of 90, 180, 45, but still sometimes they are challenging. The positioning of the EWCs, again, with respect to your biopsy, is very important. And I'm not sure what is sorry. I can't see my last breath holding. So some of the times we have seen that when the nodules are very close to your diaphragm, there's a lot of airway movement, and you can see your nodule with respect to your locator guide. And many times I just ask them to breath hold either in expiration and inspiration to see which gives me bring me close to that nodule. And this helps in some of the cases, particularly when you are very close to the diaphragm. I think the success depends on the teamwork, brightly from your anesthesiologist, following the protocol. Pathology, we also use ROSE all the time for all our cases. And we are also actually helping preparing slides. I also personally look the slides with the pathologist. And then radiologists, as well as the fluoroscopic guys, they are very important. They come in and help us out with the fluoroscopic navigation. Future market placement, again, the radiation oncologists, we work with them very closely. Majority of the people we work with, their recommendations or requirements are to place the markers within 2 centimeters of the nodule. They prefer like about 4 markers, at least if we can place it. And then if they are in different planes, so that their machine detect them as a separation, not considered as the one marker, even if there are 2. Referral and networking has worked very well for us. I work very closely with interventional radiology. We do review cases, and I do get a lot of referrals from them for the high-risk cases, and has generated enough confidence in community as well as in the colleagues with oncologists as well as surgeons that we are able to reach to these nodules without much problem. So I don't hesitate sometimes to send some of these cases if I feel they'll better serve to the CT guided approach. As far as program growth is concerned, I started this program about close to 2 years ago at Baylor Hospital. We have done almost 300-400 cases total since we started this program, since I would say about March of 2020. And we started doing ILLUMISITE somewhere about July, August of last year. Done close to 100 cases. I do have some prelim data I didn't put in the slides, but I can, our experiences, we have done cases from 0.8 centimeter to 2.5 centimeter with average size about 1.55 centimeter. 60% of nodules were upper lobe predominant and 40% lower lobes, but they are everywhere in the lung, peripheral nodules small, and we are able to reach these nodules. Our first pass biopsy success rate was about 78% in these cases, and we had about 90% accuracy in diagnosing these nodules so far. And our complication rate was 0 pneumothorax and 0 hospitalizations or bleeding. With this, I will stop here. If there are any questions or comments.
A few questions we'll ask of you, Dr. Suri. So great presentation and fun to see the success you're having with ILLUMISITE. One question would be, how has continuous guidance helped shape or change your biopsy techniques?
So we were actually looking back before the ILLUMISITE, our success rate was still in 80s before the ILLUMISITE came in. I think it's added another 4-5%, but the most important thing I see by using continuous guidance is I'm able to actually get the biopsy from some other areas, and as some of these areas of necrosis, as Dr. Hoopman mentioned. So I do also use sometimes for a bigger nodules just for the sake of getting the samples for molecular studies, because sometimes you are getting necrotic tissue, and then that helps us a lot in moving a little bit on the different areas. And secondly, I'm also, you can see the structures, what are nearby structures, fluorine, you can actually know where exactly you want to take the sample from, which with respect to some other important structures.
Awesome. And next question for you would be, what's your strategy as far as the EWC catheter curve shape? What's your thought process, and how are you usually picking that?
So, compared to some others, I have used mostly the forceps biopsies. I used in the beginning gen cut, but sometimes you start sucking a lot of blood through it. And then if your pathologists are not, they're not cytopathologists, sometimes they all see is the blood. So if you're taking the first sample, you get the answer very well. For me, the forceps has worked great. Even for the 8 millimeter nodules, I biopsied them with great success. But I know that it will gonna, change the curve of my EWC. So I tend to just locate my EWC, which is maybe just a little bit away from the curve. So once I am when I'm putting my forceps, it's gonna focus right at the nodule. But with continuous guidance, that has helped you if you need to move a little bit. So if you are in, and then I go and look at the different airways, more than one airway, and see if that airway will serve me better than this particular airway, although I'm in great alignment, but maybe the other airway may be better for me to do the biopsy.
Okay, wonderful. Thank you. Okay, Dr. Gordon, you're up. Thank you.
Thank you. Can you guys hear me okay? Thumbs up. Perfect. I'm just waiting to get the slides free. Perfect. So thank you for inviting me to this forum. I think it's great to see others that are experiencing the same success that we've been experiencing down in our neck of the woods. I will echo a lot of the sentiments that have already been said, such as confidence from your colleagues. For our neck of the woods, we get more referrals from oncology and radiology, meaning they prefer us to do a first try over going straight for a percutaneous biopsy, as well as for the thoracic surgeons. They would like us to try first as well. I think that is due to their confidence in seeing our diagnostic yields. Let me go to the next slide here. Our background, I'll get into briefly the case study, but first our background is not much different than everybody in the platform, so I don't have a lot to present for that. We've developed our navigational-based platform, I think, in 2014. I have a background using the old Super Ds when the nurse used to stand behind and have to calibrate and give you the flexion and all that stuff. So I think it's nice to see the evolution, and I think everyone will agree that the concept of divergence is our rate limiting step to getting 98+% diagnostic yields. But not everybody can have a cone beam, and if you talk to colleagues in academia that have cone beam, they're fighting for time, and it's not realistic for busy practices. Nodule clinics that are seeing 50 to 100 a week. If you're going to take 20 of those for biopsy, those are high numbers. So looking at those numbers and the realism of what it's like out in the community practice, having something that is easy to use, high diagnostic yields, low risk, is giving or taking away that obstacle of divergence, put in the right hands, I think you're going to start to see these yields well over 90% as time goes on, and that's kind of been our experience. So I'll highlight my case in brief. And I think this kind of is a nice summary of what we kind of see, and most of you all probably see, is a 66-year-old female, 18-millimeter nodule, and a 10-millimeter nodule in the right upper lung, probably growing next to each other, and some could debate together, but I think clearly we did a morning repeat CAT scan, and because she came to us with a PET scan, there's definitely a difference in these two nodules. The smaller one actually had SUV unit 6.2. The bigger one did not. She's COPD, moderate emphysema, 100 pack year history, and current abuser of smoking. And she recently had COVID. Maybe perhaps part of that delay, I think we're talking less about that, but that over the last 2 years was a realism about getting patients seen and into the right clinics right away. Mayo risk calculator was pretty high. Of course, by definition, was high risk, but seeing a smoker with emphysema who just recently got over COVID, that's not a case that generally our thoracic surgeons are excited to take straight to the OR for resection. Because of we're also at high altitude, and some of you guys are, some of you guys aren't. So that oxygenation needs and post-COVID recovery complicates things. So needless to say, her PET risk, it goes up to 91%. So, the book answer is to go straight for surgery. The realistic answer in practice is that nobody wants to cut this patient open right after COVID, right? Or generally speaking, with the high amount of emphysema and active smoking. So we reviewed options, and after a risk-benefit discussion, we chose for navigation. Go to the next. So, this is kind of this conglomerate here in the upper lung. That was the bigger side. That actually did not have any significant SUV uptake. If we go to then the apical, just apical to that, the more dense consolidation here measured just about a centimeter, a little bit less than. Obviously in a medial apical position. And I think, I'm not worried. I know, I think it's great to start with air bronchogram, but my confidence with this platform is that just give me a nodule that's risky enough, that needs a biopsy, and I think you can get there majority of the time. That concept of off-roading, as you will. Anyways, we got in this case, in summary, is a nodule, apical, medial, near pleural based, just under a centimeter. We definitely have an uptake of metabolic activity. Doesn't tell us it's cancer or not. True, probably easy resection for a surgeon. But the reality of taking to a case, with the patient, I didn't put in here FEV1 numbers, but not, borderline, candidate. So doing a biopsy was what was requested. And I think for me, this is more than reasonable for the low risk that we take in a biopsy setting. So let me just go through this case. It's a video. It's going to go, I'll probably run it through twice and just kind of talk. And I like, the reason I chose this here, I might pause here and go back, is that this is just so fluent and rapid once you start doing these, on a regular basis. So you're going to go and you're going to do your touch point calibrations. You guys can agree or disagree. You're maybe looking at 1 to 2 minutes max of time here. And we run our patients, like most of you guys, under general anesthesia, and usually just a deep sedation. Unless I have coughing, I'll ask for paralytic. I usually take that off when I get to the linear probe EVIS for staging. But anyways, you go down. You're just going to touch your airways. You're going to mark it. You're going to calibrate. I always like to look at this to see if I have a nice, airway going up. But you can even see, like, I'm pretty far from this thing, and we already know it was so far up. So, oh gosh, let me go back. Who let me drive? See if I can hit the back arrow. Give me a second here. Can I ask for some assistance in getting back, guys? Richard? I'm gonna stop remote and see if you can just get me back to the other screen, because my button.
Sure. Stand by.
Yeah. Okay. So, anyways, I'll keep talking as we run through. You can look at the beautiful mountains in the background. It's a good thing to look at. So, the calibration is easy. Once you're kind of lined up, and the reason I chose to stick with the ILLUMISITE as I move forward and advanced, you can keep going back to the video slide, Richard, if you can, is because the navigational components and getting a working channel out. One more forward. Nope. Yep, right there. Okay, I'm going to go back to request remote control and what it thinks about it. We'll run through that video. So perfect. Okay, so in this case, I'm going to go back to the case as I'm talking. In this case, you can see navigation really wasn't difficult. I like the catheters. I like the ease of navigation with the platform. I feel like we can get to any green ball, as you would say, almost every single time. I can't think of a time in the last 2 years we haven't been able to. And so we get there, everything looks good, but I'll go back here. I'm nervous about making this slide go back. Damn. If you go back again, Rich. I don't know why it won't highlight the video video for me, so that I can slow it down. And we were able to do that at the beginning. Yeah, perfect. Yeah, that's it. That's what I want. Perfect. I'm just going to hold this button down here. I lost it again. Anyways, I'll just keep walking. So when we got here, what I usually do is when the ball's in front, I'll stick a radio probe out. And when we stick our radio probe out, you'll see in the bottom left, it'll just be there for a quick glance. We didn't see anything. We just saw lung. So we knew we were not at the lesion. We mess around usually a little bit. From at that point, that's usually time I choose to do a sweep. I don't always do a sweep. If my radio probe is positive and I've got a nice concentric view, I'm going to go ahead and start my biopsy. But in this case, we go ahead and perform a sweep, which really is just a few minutes of extra time. This is kind of what it's like for me, going through, is we're going to go ahead and try to find the lesion. So we'll go back and forth, and clearly you can see in the right upper lung. Sometimes we'll go back and forth with the CAT scan just to make sure that what we're looking at isn't a shadow. Looking at it is not a shadow. And so then we'll go ahead and select that. We'll go ahead and bring it with a spin to the left and a spin to the right, making sure that we keep that nodule exactly where we want. And then we're off to the races. And boy, we were pretty diverged there. And really all I had to do is extend out about 2.5 centimeters. And this is what we're looking like. At the bottom left, you'll see the rebus that kind of went away, but we did have at one moment a nice, there's some eccentric views here, but we did get it to a concentric view. Once we got the concentric view, I usually do a first pass needle. You can see in real time the needle going back and forth. It's really like a perfect case. We got first pass call on this, by the way. So there's a nice concentric view in the bottom left for rebus. And typically my process is I do a needle pass for slides, then I'll do a biopsy, then I'll do a brush for slides. That gives our team some time to make those slides in between with rapid on site making calls when they're available. And I'll just keep working that process. And usually I stick the radio probe in each and every time before a needle, just to make sure that I haven't moved. I think obviously the positioning of your hands is if there's any weaknesses, you sometimes turn a little bit, and little turns can make all the difference, and nodules that are less than a centimeter. But again, as you get good, you're pretty taught, and this is part of your training. So needless to say, we were able to, you can see this is a right on view, great case, first pass positive, able to spend some time to get some extra tissue for genetics, able then to go back and stage the mediastinum. And this is a case that probably lasted 25 minutes max. And that's staging all 3 mediastinum lymph node stations, getting biopsy with extra tissue for any genetics, and having no complication rate. So it's hard to argue with these types of cases. I'm going to go forward. Now I'm ready to go forward. So our pathology basically showed just classic adenocarcinoma. Nothing special about these slides, and not surprising based off of where it was sitting. So my conclusion is floor navigational, and I put correction there. ILLUMISITE is right. Look at this, is because really what we're doing, the way I conceptualize this is we're doing our best with a fluoro pass to do real-time anatomical changes and correcting the divergence problems. I won't spend a lot of time in technique because you all before me have done a great job at talking about those little niches that we need to do, such as a little bit extra PEEP. I do like saline if you need it. As far as tools, I'm a needle pass first. I think that's what's going to get you your diagnosis. But we've done the triple needle, we've done the gen cut in the pass. I just feel like the needle gives us less bleeding and better diagnostic yields. I think a lot of literature probably supports that as well. I am more of a fan of the rebus. I think like all you probably use it in every case. I use it kind of continuously through my case because in my mind, that's my real-time correction in case I've made a human error, I've moved, a patient's coughed, something has happened that maybe I don't want to stick a needle in a concentric or view that's not nice and pretty. But anyways, I think you guys agree that the rebus images are phenomenal, and I like to do that on each and every prior to each and every FNA needle biopsy. But again, looking back at this, I think each of these steps adds diagnostic yield. So for me, it's you get into the 70% just using a basic navigational platform. I think you guys attested to numbers in the 80s, or adding a few percent by adding a correction factor with a real-time scan under fluoroscopy. I think then you add a needle, probably gets you another 5-10%. You add a rebus, gets you another 5-10%. And so we're shooting numbers above 90, and I think that's realistic for everybody that uses these types of platforms. As I put before, not all cases need correction. So in a busy practice, like I think somebody was saying, they have 5 cases tomorrow. To do 5 cases and maybe you're covering an ICU or doing a palm service or something, and that's how the real world works. It's not, I have this vision. I never walk out of a case, and if my case lasts 2 hours, that's what my case takes. And that's the benefit of having rapid on site to make those calls and get you moving faster. But needless to say, it's nice to go in and plan for an hour and a half case and be done in 20 minutes with all the things that you need, with all stations sampled, with tissue positive, extra tissue for genetics, and really walking away giving what I would consider state-of-the-art diagnostics. Again, I don't always need to run the ILLUMISITE the fluoro flyby, but I do use it probably 50% of the time. when you get to sizes greater than 2 and 3 centimeters, and you kind of attested, you did a cutoff in your data collection at 2.5, and I think that's perfect, because once you start getting above that size, I don't know that it's necessary that you need to do the ILLUMISITE, but the platform of the old super dimension and the way that the catheters work and the ease and proficiency is, you don't need much more as far as what you invest in as far as your program goes. And then I think, I don't know if I have much more to say. I think the more you do this, the better you're going to get with these types of cases. Selecting a team, I'll just conclude to say selecting a team, I think, is paramount. For us, I have, we have 2 different hospitals that we'll have this at, but at one hospital, we have the same respiratory therapist, and he did the old superdimensional training out in Minnesota many years back, and has really kind of headed up his platform. We have people that help make the slides that are consistent. We have different pathologists that will come in a different room to make the calls, similar to everybody else, but they're right there to make the calls. We have basically 2 fluorotechs that know exactly how to run it, and even going back to our anesthesiologist, we really just have, it's not always the same anesthesiologist, but it's the same 3 folks, and so they know what we want in the vent. They know how we want to run the case. We know how to communicate, and I think, like anything in life, having a system with checks and balances and everybody educated and knowing their role will also increase your yields moving forward. So that's what I've got. And if you have any questions, I'm happy to entertain them.
I do. Thank you so much. Great to see the success that you're having and some of the pearls of wisdom that you shared. A question for you is, what is your strategy around catheter selection?
Yeah,
the curve that you're picking and how?
I'm pretty universal. We use the 180 every time. We found that we never used a 45, so we don't even have those. I do have some 90s, and I'll reserve the 90s for basically masses, like the scenario of like a 4 centimeter mass sitting in, the right lower lung, main airway, huge, airway sign, bronchus going right into it. That one, I don't really want the curve, but, I find over time, and you can do a couple things with the catheter, if you are savvy enough. That case that I illustrated, it's perfect for a nice 180. And I like the 180s because it gives me the ability, that term of off-roading. So if I don't have an airway or I have a pleural-based nodule, I feel like the 180, I call it corkscrewing. I don't know if there's somebody has a better terminology out there. They probably do, where I can just kind of rotate, and you will, it's those little things that you get in training and doing this over and over again. It's that little feel, it's that little biofeedback that you get, and you'll feel it kind of click into the airway you want, and you can start advancing and maybe a twist and kind of circle around, and then I have it kind of pop into the airways that I want it to go. So I'm for that reason, the 180 gives me that advantage of, I know that although I'm not like this in the airway, I always have a sense of torque. So as long as I keep moving that torque the way I want, I can go wherever I need to go. And so I've made that opening statement that I think it's in, and I can't say this for sure because I haven't looked at numbers, but anecdotally, it's been over 2 years, I think, since I've not been able to reach the green ball, maybe even 3 years at this point. So as far as using a catheter and getting to the green ball, that's not the issue to me at all. And I think to our users on this forum, I don't think that's our issue. Our issue is the divergence factor, and ILLUMISITE takes the divergence away. And that's why we're here.
Wonderful, thank you. So one of the questions I guess I'd like to pose to all 3 of you is, you all had a choice to pick the technologies that you wanted for navigation. We certainly know there are choices out there. Could you speak up to a little bit as to how you chose ILLUMISITE?
Can I go first, Jody, or Josh, do you want to?
Sure.
No,
yeah.
why don't we just go in order?
Go
Yeah.
Okay. Yeah, I think that's actually a really important question, particularly in community-based centers where cost and return on investment are very important discussions that are held in the boardroom and held in the C-suite. As we were looking at various platforms back in 2015 and 2016, these were the questions that were posed to me: is how do we know that number one, this is going to work, and number two, how do we know we're going to get our return on investment for an expensive piece of equipment? And one of the factors that really played a role in my decision, and at least in my recommendation to the board, was that I felt very supported from a technological standpoint, meaning I had the understanding of the system. I knew what it could do. I knew what it had done in the past, and really had kind of seen a glimpse of where it was going in the future. But the other part of that, which I think was just as important, was I got a lot of support from Medtronic in particular for how to build a program. And it wasn't just deliver a machine on June the 1st and unpack it and teach a few times and walk away. I really felt like there was going to be some help with how to really grow the program around the technology. And I can't say I can say with certainty, pardon me, that that's exactly what happened. We brought in amazing technology, but through some guidance, some assistance, and a little bit of gentle nudging, we were able to realize that the program could be built around this. And as a result, we met our ROI in the first 16 months that the machine was on site. So when it came time to look at moving to the ILLUMISITE platform, it was a really easy decision for the institution. And in today's hospital environment, because of what happened with COVID, and so many hospitals that are trimming their capital budgets and really reevaluating where they're spending their dollars, I think you really have to look at the technology. Does it work when I use it? Is it going to do what's provided and what's promised? But then more importantly, can I build something around it that sustains the growth and brings in additional revenue down the line, whether it's oncology services or thoracic surgery services or referral basis, because that's really what drives the growth for community centers, is the referral basis, particularly if you're in a market where you have other competitors.
Great, thank you. Dr. Suri?
Yeah, I agree with Dr. Hoopman that cost plays quite a bit of role in community practice. And again, I've grown with this technology. I've been using since it was introduced in 2007, and I've grown with this. And this is ease of the technique, and then again it delivers what you want. I've noticed the advancements and the technology over a period of years. Now there are different platforms available in current world, but majority of the data, majority of the studies, most of the work is been done on Medtronic. And not that I don't know if the other platforms have something more to offer, but I have not felt the need so far that I need something else to use besides the ILLUMISITE. Only thing I would say, if something I need, is maybe a catheter, if it's a little bit more articulating. I mean, maybe the only thing I may want within this platform, if there's some difficult areas, we can easily navigate those. Apart from that, it has worked. The data is phenomenal. Support has been excellent, and our results speaks for it. So to spend 3-4 times the dollars when you can get the same results from ILLUMISITE, plus as Dr. Hoopman said, the future, if we need to see this thing is going to take us to the next step. I agree with him completely in this.
Wonderful, thank you. Certainly, I know one thing I can quick say is the number of procedures you're doing in a day, for example, 5 tomorrow would be probably harder with some of the other technologies, no doubt. So efficiencies, I know, is something we definitely can hang our hat on. Okay.
So I do about 8 to 10 a week of these cases, and Friday is my day where I do about 4 or 5 cases. And our average time is about 20-30 minutes in each case. So certainly you can't beat that.
Great.
Absolutely.
I would agree with. Oh, sorry. Did you want me to put 2 cents in?
Yes, please.
So I was gonna say I agree with everybody's reasoning for choosing this platform. I would add just a couple more items. Is if you're getting 90 to 93% yield, I'm not sure what's going to beat that. And for the price, you're half the competitor's price. You still can add a cone beam to this if you wanted to in the future, but what is that getting you? Another couple percent? I don't even know that you really need to. And I think as users become more efficient and their teams become better at what they do, that's going to be adding that extra 1, 2, 3% to now you're shooting, upwards of 95%. And it's just hard to argue, why do you need a cone beam for $1 million or other technologies that are more expensive when this is getting you what you want with, again, low complication risk, good diagnostic yields. You got to go in and stage the mediastinum anyways. I mean, it just really is the ideal platform. My confidence with Medtronics moving forward is, and you already said it, is the evolution. And I think that you all are invested in this from the beginning, and we keep seeing things just getting better and better. So it's nice to stay with a platform that's continuing to improve. So that's why I stick with it without hesitation.
Wonderful. Well, I really appreciate all of the comments, the feedback. It's great to see the success that ILLUMISITE has brought you. I know we're proud of the technology and appreciate what it's doing for our patients and for you and your practices. So I just want to put a heartfelt thank you to Dr. Hoopman, Dr. Suri, and Dr. Gordon for being here with us this evening. This call was recorded, so we will be sending out a copy of that to all that attended. And please reach to your local sales reps if you have questions and have further thoughts and considerations on the technology. Or I know any of these three gentlemen would probably be happy to answer any questions for you as well. So with that, everybody, have a wonderful evening, be safe and healthy, and thank you again for attending. Take care.